Good evening, everybody. So this is a short quiz. There will be a image will be projected, and you have to identify the case. Following which there will be 2 questions. Each has got its own marks, which will be displayed in the screen, and accordingly you will be awarded. There is no pass for this. So you can partition is done as A, B, C, and D. So we'll go to the first question, and before that I will just show an example. So this is the first session. 4 questions will be done by myself, Dr. Indumati, assistant professor. Next 4 questions will be done by Dr. Uma Devi. She is also an assistant professor. This is an example. So you have to identify the lesion. This is just an example, not a quiz. But not with that. You have to say what is it. Okay, it is explain the images. So it is an example, so it is actually simple. It's a mucocutaneous disorder with fibrinoid necrosis of a medium-sized vessel and with coronary arteries involvement. So this is a question also known as mucocutaneous lymph node syndrome. Which vessel involvement? Medium vessel. This is an example. So we are going to the quiz now. Team A. Your time starts now, 30 seconds. Timer.
Please follow the time. That's 30 seconds for team A.
You can present as a, what is this? Team A.
What about A? Someone's ready to answer, sir. This time.
Sir, no pass, sir.
No pass.
No pass.
No
pass.
A. The one who is ready to answer, please raise your hand so that it will be easily visible.
LCH.
Okay.
Very good. Can you explain it?
That is a punched out lytic lesion in the bone.
Yes.
Supernumerary teeth.
Okay.
Here you have eosinophilic granuloma.
Okay.
Above slide.
And the marker here is?
I do not know.
Very good. Okay. This is the coffee bean appearance of the cells having grooved nucleus. So now only we are going to the question as such. Eosinophilic granuloma. Is there spontaneous resolution? 5 marks for this question. Team A only. Is there spontaneous resolution for this? Say yes or no.
Yes.
Good. 5 marks.
5 marks.
Question number 2. What are the other tumors which has got spontaneous regression?
Okay.
One more? No. Ameloblastoma? No. Time up.
Okay.
Malignant
2.5.
melanomas, neuroblastomas, germ cell tumors are common tumors which go for spontaneous regression, and later in life they can present with metastasis too. So 2.5 marks for the second question. Third question also for team A. CD1A positive in Langerhans cell histiocytosis. CD1A positive in other tumors. Any 2 tumors? No. 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 Okay. Cutaneous T-cell lymphomas, thymomas, granulocytic sarcoma means AML, soft tissue depositions, and TALL. TALL is again very common for CD1A positive. Just leukemic deposits in the skin can be a T-cell lymphoma, or it can be a TALL leukemic deposits. Just by seeing CD1A positive, we should not call it as LCH. So we are going to team B. Wrong.
CMB.
Can you explain it?
Microcephalic chorioretinitis, hearing loss, periventricular calcification,
Owl eye inclusions. Very good. So now is the question for you. What is false about congenital CMV syndrome? It is one of the torch infection. Only 20% of the infected fetuses are symptomatic. Most of the antenatal mothers who acquire the infection are asymptomatic. Clinically, they present with large weight babies, microcephaly, conductive hearing loss.
Large for weight babies, microcephaly and conductive hearing.
Why?
They present as IUGR, SGA and sensory neural.
Very good. 10 marks. Question 2 and 3 and 4 also for team B. Team B. It belongs to herpes viridae family. True or false? Team B only to answer. Very good. 5 marks. Once infected, your body retains the virus for life. True or false? True. 10 marks. So 20 marks in full. Case 3. Team C. This is a newborn. What is this? Yellowish discoloration of the eye. So it is. Let them.
It's okay. This is a
It's
bit
little
difficult
bit-
question because histology, yeah, it will
Okay, I'll give clues to find the case actually. This is, what is this? It's conjugation. Conjugated hyperbilirubinemia in a newborn with hepatomegaly. And liver biopsy shows multiple giant cells within the hepatocytes. Can you identify the lesion now? No. Okay, it is infantile giant cell hepatitis, cholestatic liver disease of infancy. So the question is, you can answer the questions. Name any two intrahepatic cholestatic disorder and extrahepatic cholestatic disorders. 10 marks for this.
Intrahepatic cholestatic disorder, metabolic disorders like galactosemia,
Okay.
hereditary fructose tyrosinemia, hemochromatosis.
But the pathology is outside the liver. I'm asking the pathology within the liver itself.
Congenital hepatic fibrosis,
Okay.
bile duct PFIC syndrome,
Okay. And extrahepatic?
polylocal cyst, biliary atresia.
Yeah, for extra hepatic.
Very good.
And give it off.
So this is Alagili syndrome, Byler syndrome, giant cell hepatitis are intrahepatic, extrahepatic, biliary atresia, primary sclerosing, cholangitis, bile duct stenosis are the examples. 10 marks. And next question. Can you match the following? Time up. Team C. Option number 1, 2 or 3 or 4. Huh? 2.
2?
Very good.
Right?
Yes.
It's actually a difficult one. So Caroli's disease is communicating cavernous ectasias. Byler's is a form of PFIC. Alagili is a paucity of bile ducts. And PSC is repeated inflammation leading to fibrosis of bile ducts. Going to Team D, question number 4.
Downs.
Okay, explain
Single
this.
transverse palmar-crease.
No, okay. One more finding in the hand.
Clinodactyly.
No.
ATD angle. Narrow.
Huh? Absence of middle phalanx in the little finger. You can see only
Two phalanx.
2 phalanxes are there, both the
Cardiac
hands.
defects.
Okay.
Third one, cardiac defects.
Cardiac defect, can you mention which is the most common one?
Endocardial defect.
Okay.
Endocardial defect.
Presenting as ASDs.
ASDs.
And what is the lower one?
AML.
AML. So
AML, M.
leukemia, if at all, happens in a Downs, which will be the M7. Very good. Is there any characteristic feature for M7 megakaryocytes?
Megakaryocytic.
They will have cytoplasmic blebs, which is appreciated in the picture. You can see the cytoplasm showing blebs. Very good. So question is now 2 positive and negative markers for AML M7 in flow cytometry.
Translocation 15 some.
No, in flow cytometry. CD markers. Megakaryocytic markers.
1920.
No, 1920 are B cell markers. Megakaryocytic markers. And 2 negative markers, because you are supposed to read flow cytometry reports. You are the persons who are going to receive the reports. You should know. So when these markers are positive and when these markers are negative, you have to identify one or rule out the particular leukemia. Anybody? Any tries?
Negative for myeloperoxidase,
Very good.
neuron specific enolase.
Okay. Positive markers?
Positive,
Okay, good try. 41, 61, 13, 33. 41, 61 are specific markers for megakaryocytes. MPO for myeloid markers, which will be negative. Glycophorin A is erythroid marker, which will also be negative because it is megakaryocytic lineage. Downs with AML has a better prognosis than non-Downs with AML. Is it true or false?
True. True.
Good. Why?
Good response. Good response to chemotherapy.
Why not for a non-Downs? Same chemotherapy will be given, right?
Translocation, which
Okay,
is
the protocol
just
actually
because-
differs for a Downs. Downs protocol generally responds better. Okay, a short few words about. So the first round is over. Marks solitary. Team A 7.5, Team B 20, Team C 20, Team D 15. Okay. This is few words about Down syndrome with AML. AML with Downs has 3 mutations. First one is the trisomy 21. Second is the GATA1 mutation. When a Downs baby acquires the GATA1 mutation, they end up with TAM, that is transient abnormal myelopoiesis. And when additional mutations are present, they go for AML M7. So this TAM can be clinically present. If there is large clone of GATA1 clone, they present as clinical presentation with some amount of blast and clinical presentation will be there. If the GATA1 clone is less, they will present as a silent TAM. Both clinical TAM and silent TAM, 80% of them go for a regression. And some 20% of them, when they acquire additional mutation, they go for a Down syndrome for an acute leukemia. So this is the difference between TAM and a Down syndrome leukemia. Otherwise, clinically and peripheral smear, anything cannot differentiate between them. Only with clinical presentation we have to differ, and management depends upon the clinical presentation. Thank you. And it's over to Uma.
That was a good show. So we'll continue with the second round from starting from Team A. Okay. So here's a case history: 7-year-old child presenting with pancytopenia and splenomegaly. You have to do connections. Identify the peripheral blood picture. Can anyone, say about what, comment about the peripheral blood picture? Yes, please.
Teardrops
Okay.
and then hypersplenism is there.
Okay. More about the peripheral blood smear report. What about the? Okay, there are 3 lines, right? RBCs, you see dacrocytes, and WBC, and also you see nucleated RBCs as well. Okay, WBCs. Comment on the WBC. What type of cell? It's an immature cell, immature granulocyte. And what about the platelets? Do you see any platelets here? Yeah, thrombocytopenia. So what kind of picture is this overall? Where do you get dacrocytes, immature cells, and thrombocytopenia? Or you can just say immature cells in the blood. Is it a leukemia? What is similar to a... no, leukemoid will be, the count will be more than 50,000. A count which is, where you see less immature cells. Okay, I'll give you a clue, leukoerythroblastic picture. Okay, so where you get immature granulocytes and also immature erythroid series. And you are seeing splenomegaly. Okay, now correlate pancytopenia, leukoerythroblastic picture, splenomegaly. What is your diagnosis? Okay, good. So what is the bone marrow picture do you expect here? So I have actually already started asking questions. So the first question is the diagnosis, which is myelofibrosis. So they carry 5 marks for that. So what is the finding do you expect in myelofibrosis? What is that?
From
You're seeing the pancytopenia. So bone marrow, you want to know, you do bone marrow for a pancytopenia. So is it cellular, normocellular or hypocellular? It is?
Hypocellular marrow.
It is hypo?
Hypocellular marrow.
Is-
Hypercellular marrow with the pancytopenia. The bone marrow will change into reticulin fibrous tissue, ma'am, so that the immature cells are seen in the marrow. The mature forms are
Normally you get to see immature cells in the marrow. See, when you evaluate a pancytopenia, you want to know whether the factory is itself defective, whether the cellularity is less or not. Outside there is pancytopenia, but bone marrow there is hypercellular. So the more marrow is hyper-functioning here. So you have to think about either a myeloproliferative disorder or, I mean, it comes under myeloproliferative disorder. So in this condition, what is catchy? It's a hypercellular marrow with large cells with multilobated nucleus. It's megakaryocytes. So what you expect is a megakaryocytic hyperplasia. And what is
thrombocytopenia. Essential thrombocythemia.
okay? Essential thrombocythemia. What do you expect in peripheral smear?
There will be thrombocytopenia.
Thrombocyte. But what did you see here? Thrombocytopenia. So, but though your diagnosis is right, you need to have that concept clear. Okay. So why do you get fibrosis here? What is this stain you need to demonstrate? Once you know that cellular marrow is cellular, you ask for the next investigation. That is reticulin stain. So you are demonstrating too much of fibrosis there. Okay. So the question is, what is the clinical condition? You said myelofibrosis, and the bone marrow findings will be megakaryocytic hyperplasia. Why is that fibrosis? Answer 3.
It is replaced, the cellularity marrow is replaced by dense collagen and reticulin.
Yeah, why is that so? Because
JAK2, JAK-STAT2 mutation.
okay, finally what happens? Because of megakaryocyte hyperplasia, they produce a factor. What is that factor? Platelet-derived growth factor, which stimulates reticulin deposition. Yeah, that's what stimulates the fibrosis or reticulin deposition and also collagen deposition. And that's the reason, okay, PDGFR by megakaryocytes. So other condition with megakaryocytic hyperplasia without fibrosis.
ITP, ma'am. Immune thrombocytopenia.
Okay, good. Okay, ITP. What else? So you are getting 2 out of 4. You got it 2 right. So I'm giving you 10 points. Other would be obviously it's a myeloproliferative disorder where you see all myeloid pan-myelopoiesis will be there. So that's why ITP, and for the diagnosis I'm giving you 10 marks. Okay, reticulin stain. Okay, 15 marks then. Okay, fine. So this is the answer. ITP and MPN. So how do you exclude ITP? If you see spleen, don't ever call it as ITP. Okay? Though there is thrombocytopenia and bone marrow hyperplasia, if you, with the spleen, ITP is excluded. Never call ITP in the presence of spleen. When there is spleen, that means there is an extramedullary hematopoiesis which favors myeloproliferative disorder, which will fall in all that CML, essential thrombocythemia, as you were saying, and also, what's myelofibrosis. So with the reticulin fiber deposition, this is more in favor of myelofibrosis, and the mutation would be JAK2. So let's move to the team B. Spot me and identify me by proving with special stains. So A, what is that cell? They all have a common cell. A, B, C, D. A, C blue, finish it. Histiocytes. So you mean it's a macrophage. Okay, it's a disease of macrophage, so you're right. And what is that cell? It's a big cell which has engulfed cells. What do you call that term as? Okay, emperipolysis, very good. Here what I am demonstrating, I want you to expect is, what is the difference between a hemophagocytosis and emperipolysis? Very good, very good. I should give marks for that. Emperipolysis is, there is hemophagocytosis, but the cells are intact. Where do you see emperipolysis? Very good, rhozoid Hoffman. Whereas hemophagocytosis, it can be either primary or secondary, you all know the history. Okay, the next cell B. What is that cell? It's all common. It's histiocytes or macrophage, whatever name you can call. histiocytes in the tissues, macrophage also, you can name it as macrophage also. So what is that cell? Gaucher's, okay. Team B, that is Gaucher cell. What is the stain you wanted to use? Okay, you identify the cells first and I'll go on to the questions. C? It's a bubbly cytoplasm, a cell with a bubbly cytoplasm. Which condition you get that? B is wrinkled tissue paper, that is Gaucher's. A cell with distended cytoplasmic vacuoles. Which disease do you ask for? Niemann-Pick's, very good, okay. And the D, this picture is repetition. It's a coffee bean. What is that? Langerhans cell, histiocytic cell. Now the question starts. So for, okay, I gave the answer also. For hemophagocytosis, which stain marker which you put? CD68 will be positive, but you have to see microscopically, under the microscope, you should demonstrate, able to see cells which have engulfed other cells, okay? So those if you have a doubt, you can put CD68. Next question is the Gaucher cells. What stain do you ask for? It's a, yeah, you said PAS. Isn't it? That boy gave PAS. Why? It's a glycogen storage disease. It stains carbohydrates. Okay. And third cell, C? Niemann-Pick. It is? What is the disorder? Then you can say it. What is getting stored? Is it carbohydrate, lipid? Lipid. So, okay, Sudan black. So you put either Sudan black or oil. It's a lipid storage disorder because of the sphingomyelin deficient. And D, what's the marker? Persian blue? Persian blue will stain what? Iron. Here. CD1A. Yeah, it's a repetitive question. Okay. So 3 out of 4. I'm giving 15 marks to B. Okay. Okay, good attempt. Next, guess this. Case 3 to team C. Can you able to make a diagnosis out of this too? Identify the clinical picture. For team C, what is that? Anyone? I can hear the answer from team B. Anybody from team C? Okay, look at the pupil size. What do you call that? Okay, I'll come to the, let me answer it. It is ptosis, meiosis, and anhidrosis. What is that syndrome? Horner syndrome. And what do you see in histology? Ma'am is focusing on that. Giving it's a rosette. Okay, B, sir, mic please, sir, to team C. She's answering. What is that?
Homer right pseudorosette.
Okay, so connect it. Down. Okay, right, very good. The answer is neuroblastoma. It's involving sympathetic upper cervical sympathetic chain, so it's presenting with Horner syndrome and has a mass, and that's supposed as showing Homer right rosettes neuroblastoma. So what is your diagnosis? It's a neuroblastoma. What is 4S? In neuroblastoma, they define this term 4S.
Sympathetic involvement.
Yeah, someone is answering, but from team A. I want it from team C. Okay, can I answer then? 4S means? See, 4S means even it's for basically children who are less than 18 months old, having, even though they have metastasis to skin, liver or bone marrow, they carry good prognosis. That means they respond well to the chemotherapy. So they are special type. When the age is less than 18 months, and even if they have all metastasis to skin, liver, bone marrow, they still carry an improved prognosis with the chemotherapy. So even for those kids, even 4X, there are some exception. If the bone marrow is involved more than 10%, then it is poor prognosis. That has to be less than 10%. So 4S neuroblastoma means the children should be less than 18 months and they have a good prognosis. So what is Kinds-Bone syndrome? Okay. Anyone? Okay, dancing eye syndrome. It's otherwise called as?
Opsoclonus
Very good. Okay. It's otherwise called as Kinds-Bone syndrome. What is opsoclonus? Opsoclonus, myoclonus, and ataxia.
Yeah.
Okay, which is this Kinds-Bone syndrome, which you see in neuroblastoma. Okay, 5 marks for that question, and for the 5 marks for your diagnosis. And what is the genetic study to prognosticate? Which mutation you ask for? After diagnosing neuroblastoma, you send the paraffin block to check for one mutation.
1B mutation.
Amplification?
NMYC gene amplification.
NMYC amplification. So, how much? 15 marks for team C. Okay. So, this is Horner syndrome with neuroblastoma with Horner syndrome. I have explained already. Okay. Now, team D, identify the blood picture. Comment on the blood picture.
Sickling.
You are seeing some sickle-like cells. Okay. Some more? Any other cells? Comment on the RBC morphology apart from sickle-like cells. Microspirocytes. Then? What is this cell? What do you call this cell? Okay. What about this cell? What do you call this cell? This cell, this cell, this cell. Yeah, helmet cells. Helmet cells are seen, otherwise called as? It's called as? Schistocytes. Okay, fine. What about the platelets?
Thrombocytopenia.
Okay, what is this?
Hemolytic uremic syndrome diagnosis.
Okay, it is?
HUS.
I haven't told there is renal failure. You should say it is probably a microangiopathic hemolytic anemia. Yeah. Only when if I say there is a renal failure and thrombocytopenia, you should comment on HUS. And if it involves a neural system, then it is TTP. So with renal failure, it's called as? With renal failure.
Renal failure, HUS.
HUS.
With neuro and fever, it is TTP.
Okay, very good. What is the toxin associated with it?
E. coli O157H7.
Okay, it's other. Okay, it's always called very good, verotoxin or Shiga toxin. But it's the strain of E. coli. Okay, I'll give you marks. Which receptor in the endothelial cells gets affected?
Adam TS13.
No, that is for TTP. Yeah. It's GP3 receptor in the endothelial cells, which is usually present in the endothelial cells of glomerulus. That's why this toxin has affinity to the receptor, GP3 receptor in the glomerular endothelial cells. That's why they are having hematuria, microangiopathy, fibrin platelet thrombi, and causing thrombocytopenia. Okay. So that's the answer. GP3 receptor in the glomerular endothelial cells. So I'll give you total. Yeah, it's over. 15 marks for you. Okay.
Total marks.
So total marks. A team so far 22 and a half, B team 55, C team 35, and D team 30. So the leading team is team B. Oh, 35. I'm sorry. Team B and team C both carries 35 marks. So we'll go on with